So welcome to the OrthoEd segment. Again, we're joined by Dr. Jeff Hall. How are you today, Jeff?
I'm well, David. How are you?
I'm very well, thanks. We're finally getting around to finalizing my treatment plan for my mouth. So we're looking at my case. If you're on the podcast, check this out on YouTube or on dentalheadstart.com/orthoed. What we're looking at today, we're just finalizing a few things. Jeff went through, if you haven't already heard them, Jeff went through a few things about diagnosis, risks, and some of the initial treatment plans. We have decided to remove my 3-2. And as we then do that, the staging, we're moving the canine and 3-1 first, so they have space. We're then going to put some mesial root tip called cable bends to counteract some of the tipping that may occur. What we want to look at today is just the final little bits. We want to talk about some of the attachments. One of the first things I wanted to ask is each of the attachments on these teeth, I haven't changed them a lot, but I wanted Jeff to just quickly talk through what he sees on each attachment and what we should be thinking about with each of the movements. So Jeff, you can take over and have a look at those.
Okay. I think if we bring it down to some basic principles, whenever we're looking at a mesial-distal movement in any form, we should be looking more at vertical attachments. And if we're looking at vertical movements, we look at horizontal attachments. So the first thing that I can see here, and let's just have a look at the lower arch here, that what I want to see is on this lower central incisor, I want to see a very long vertical attachment to control the tipping. Otherwise, you've got nothing to control the tipping. So the fact that you've got this very minimal attachment is basically going to do absolutely little. So even a 5mm attachment, the longer the better, and the same would apply to these canines as well, because we need to control it. And so when we move these teeth across, this is really good. What you just said before, David, is so correct. We want to make sure that we've got total encapsulation of the mesiodistal surface of the teeth. And that's going to also add to our control in any of our mesiodistal movements and control the tipping. So this part is absolutely perfect, and this part is absolutely perfect as well. So
can I ask two questions about that?
Staging is really good. So here, but I would like to see much longer attachments on these teeth. The bevel that you've got on this canine is good, because the bevel means you're pushing from the distal, which is perfect. But there's no real bevel here on this central incisor. So I'd like to see a bevel more on the mesial, because whenever you've got a bevel, and we're going to discuss that with some of the other attachments, it's far more forgiving than having just a straight edge. Because as soon as the aligner stops catching that edge, it stops being effective. So having a bevel, you've got more surface area to be able to push against, and therefore it's a far more forgiving type of attachment. Which
That's something
from a building point of view.
Myself as a clinician, first learning about that, it was something that was a bit counterintuitive. I was thinking, all right, so the bevel, maybe to help you get it out, maybe, and then you push on the flat surface, but that actually doesn't work. So as soon as it disengages, you lose the whole movement. Yeah. I found that really important.
Yeah, look, it does work, but if it doesn't work, you're basically stuffed.
Yeah.
Okay, so it's just
it works until it doesn't.
That's exactly right.
Can I ask two questions just about the 3-1 and 3-3? First question is, do we want the vertical attachment on 3-1? Is it best to have it as far gingival as possible to help with the root movement?
Absolutely.
And so obviously as long as possible, but also as gingival as possible. The second question is, and when we look at the canine movement, it's rotating quite significantly and extruding. Would we then move that attachment perhaps at an angle to counteract, to add for both movements?
You could do, but you've got to decide what's the most important movement.
Okay.
And I think the most important move in this case is getting the root in the right position.
Yep.
So he's going to be tipping. So to me, because you are so overwhelmed with that part of the movement, I would just still go with your long vertical attachment. And then if you've got to do some more correction down the track, you can always change that attachment into a horizontal or a sash attachment that we're going to talk about, and you can do that in your refinement. Because you have to assume there will be a refinement here.
Yeah, that's a good point too. With that, that canine again is going to be one where we have a risk of it not tracking.
That's
Is there any
exactly
tips you can give us about ensuring it does track or getting it back on track, perhaps?
okay. Well, I think the first thing that is what you've done is perfect, is by having that space mesodistal and encapsulating it. That really is the key, and obviously the the type of attachment. Now, to get it tracking better, the patient needs to use the Chewies, okay, or a vibration machine. I was speaking to a really good orthodontist in America called Donna Galante, who was actually one of my old instructors at Philadelphia. And Donna was saying to me that in their practice they use V-Pro, which is, and they have found that the seating is so much better of the alignments. And so tracking is obviously the key to it. But I think the other point is, what's a contingency plan if that doesn't rotate properly? So we could do some simple things where we could do, let's say it doesn't rotate, it stops rotating. We can do a little button cutout here. We can just get a little plot. We can get special pliers. We can do a cutout. We put a little button on there, and we just run some power chain from that tooth to this other tooth here. Okay, and we can help to rotate that tooth at the same time and get it back into the aligner. So as soon as you stop seeing it tracking, you can do all of that. And in fact, we're putting on an advanced course at the end of the year, and we're going to show you different types of attachments that we can use, where we can actually bond these long attachments, and we can have them right down here, and we can move the roots together. Because one of your biggest issues with all aligner therapy is the tipping of the teeth. Now, we're going to try and overcorrect it, but moving the roots together is always a challenge with aligners. Yeah, it can still be a challenge with fixed braces too, I might add, but we've got a lot more flexibility with regards to braces. So we can incorporate what we call auxiliary appliances to help resolve that issue.
I think just pointing something like that out, the fact that we can use auxiliary techniques and other things than just the aligners, I think is a crucial part of why we should learn more than just aligner therapy. And that's what I like about, what I'm learning with you. And that's why a more comprehensive course makes sense.
Well, so that's right, because I think we've dumbed down aligners too much, and it's just all it is just another way of moving teeth. But we still got to make the right diagnosis, which comes down to what we talked about in one of the previous sessions. I think your first ClinCheck, if I remember correctly, was a non-extraction approach. But it's still up to the clinician to make that decision. And when I was looking at the table of movements, and
it's in the drop. Yeah.
Okay. So when I was looking at the table of movements, when we do a non-extraction approach and we look at the buccolingual movements, basically we're moving the 3-1 and 4-1 actually slightly lingually, bringing it back into the bone, and the 4-2, 4, or the 4-3 in particular is just being moved out minimally buccally. Now, if we go back to, can we bring up your original treatment plan for a second?
Yeah, it's the other tab on the top left. You'd have to click.
That one?
No, right up. I'll just do it there. There we go. This is it.
Okay. So if we go to the tooth movement table.
And the lower.
The lower.
There we go.
So your 4-3 was being moved 1.6 millimeters buccally in your previous approach.
And look at 4-5's 3.2. You can imagine how far that's moving outside of the bone.
Yeah, but that's if you can even do that. Because if you can't do that, let's say, because realistically you probably get about 50% of the expansion that you build into it. What that will then mean is you've got programmed 0.3 millimeters per contact point of IPR. Now that's based on 3.6 millimeters of posterior expansion. So if we only get 1.6, which is probably more predictable for you, that means I'm going to have to do 0.5 or 0.6 millimeters of IPR. And that's where this whole concept of the IPR that the aligner company shows you is total garbage, because it's all based on this prediction, and this prediction will not happen. So therefore, you're going to do more IPR than what you're being told to do in the aligner setup. And that's one of the biggest mistakes people make, is they look at this and they go, that's the amount of IPR, but then you end up with more binding and the teeth won't move.
Hmm. That's a really, really good point. It's easy for us to not associate the IPR to the other movements, because it's all interrelated.
Totally interrelated. And that's what people forget. They think, this is what I call cartoon odontics. Yeah, it looks great, but are you going to be able to deliver it? And this is where no technician can do this and can predict it. This is your intellectual property and your skill. And this is why you guys as dentists should be doing this and not Smile Club Direct. For numerous other reasons as well. But that's the main reason.
So what if I came to you, Jeff, and said, Jeff, you're not taking out 3-2. How would you manage that patient? Is there a way forward, or is it more of a education communication to get them down the path of extraction?
I think it's a combination. I think it's obviously you've got to educate them. I think you'll get, and I think you've got to educate them from the point of view we might get more recession. So, for example, your 3-2 is you're moving back, but you've got to move it back quite a bit from where it was initially. But you look at your initial photos, we have to make a clinical decision about how far do you want to move that tooth back into the bone. Is 1.5 millimeters, is that significant enough? See, I look at that clinically and go, if that was me, I'd like to move it back at least 3 millimeters, 3 to 4, from a clinical point of view. Now, with the non-extraction approach, you're only going to be doing 1.5. That's your best scenario, my dad. Okay, that's your best scenario. So you'd have to educate the patient that depending on what their chief complaint is, and I'm sure your chief complaint is that the recession on that lower left lateral, that would have to be one of the main ones. Then you've got to say to yourself, okay, how much are we going to improve it and give that patient an idea? Well, we're only going to get 30% improvement. So that's one part. The other part is you're going to have a real issue non-extraction, because even if you look at the upper movements as well. And I don't think people do this enough, because to fix up the crossbite, you're going to have to move the upper lateral by 1.7 millimeters, and also the upper canine. So you are now making this canine also prone to some resorption as well. And this has happened to me with one of my patients who kept on saying, I want more expansion, I want more expansion. And stupid me did more expansion. And we ended up causing significant recession. And so you've got to be careful how far can you move these teeth as part of the biology of bone. Unfortunately, it's not scientific. I wish it was, but it's not. But
so we're thinking about biotype, we're thinking about the bony profile, but there's a bit of experience that comes into understanding that, I guess.
Unfortunately, this is the art part and not the science part.
Yeah.
Because when I look at your biotype, it's not too bad apart from that lower left lateral. So I would say clinically I'm not too concerned, but I am a bit concerned about that upper left lateral. Now, if I'm not mistaken, when we discussed this the last time, did we have a Bolton analysis done?
Yes, we did. Yeah.
Small upper laterals.
Is that Bolton's?
I think it's under tables.
Oh yeah. Yep. Thank you.
So we move this across. Okay. So you've got a mandibular excess. I would have thought you had a bigger mandibular excess than that, because to me your upper laterals look small. But I would have thought clinically it would be at 3 mils, which would also tend to indicate a good reason to do a lower incisor extraction.
Yeah. What's your Boltons that you're looking at? What's the cutoff for you? And when you think about that, like, is it over a certain number? You're like, no, definitely extraction.
Oh, if it was over 4 or 5, because as soon as you hit 5 millimeters, you've got to say to yourself, there's another part that we've got to talk about this as well. As soon as you say 5 millimeters, well, that's a lower incisor too. And which means you either have to do IPR to 5 millimeters, which is a lot of IPR over 16.
Hmm.
The other thing that you've got to look at from a clinical point of view with you is your minimal overbite, because any non-extraction approach is going to flare the teeth forward and open the bite. Now, it's less so with aligner therapy, because if you were doing that with fixed braces, you'd be really concerned about opening that bite. So, but if you decide to extract a lower incisor, you're going to be far more controlling of that overbite situation.
The other thing you mentioned, I think the other time, was that with aligners, we've got that plastic in between the back teeth. I'm also a bruxer, so that we might actually get some intrusion naturally from that as well, which is helpful in this situation.
Yeah, to me, aligners are the treatment of choice in a minimal overbite or even an open bite situation.
Yeah.
I would rather treat you with aligners than with braces in those cases. Now, but the converse is true though as well, that in a deep bite case, aligner therapy can be really difficult. To extrude the posterior teeth can be very difficult. So opening the bite is a challenge in a lot of cases with aligner therapy.
Yeah, that's a good point. It makes sense from the pressure on the back teeth, especially as I'm a bruxer or a splint at night. So I'm going to give my aligners a run for their money for sure. I wanted to just mention one other thing just quickly. We're talking about recession lower right there, 4-3, sorry, 4-4-4-5. If we just look at the way that this the bone expands here, I see that and I'm really, really concerned about the lower right. Do you feel the same way, or is there a bit more to it?
I'm totally concerned, because if we're going to expand the lower to that level, we're going to have to, if we go into the upper, I'll guarantee you've got to expand the upper to the same amount, because you've got a perfect occlusal relationship that it has expands. Yep, so you're doing a lot of expansion in both the upper and the lower.
Yeah.
So now you've got two different areas of unpredictability, the lack of predictability. So, so the chance of success, even though it looks like a great picture, to get a good clinical result at the end would be difficult. The other problem that you've got, if we have a look at the lower occlusal view here,
the photo or the
ClinCheck. Okay, so let's do some movements on that lower occlusal. Okay, so when we move, so you can see as they're moving this tooth, you've still got this constraint going on. So unless you make sure you clear those contact points and you're rotating this tooth at the same time. So really what you need to do is get this tooth through first and then start the rotation if you were doing this as a non-extraction case.
Otherwise we get binding and you just freeze. Would that be right?
Sorry?
We'd get binding and then the teeth would not be moving. Is that what we're
expecting? Absolutely. Yep, absolutely.
This is something we'll do another episode on these kinds of tips as well, because that's something I've personally experienced and learned from very quickly. So that's really good.
We all have, and we can get frustrated and believe aligners don't work. And yet, if you get these clinical tips right, they can work very effectively.
Makes a huge difference.
If we go back to
just up and then this tab up here, sorry. Yep.
So this is where we're at today.
That's correct.
So now the question comes as to these other attachments that you've got. So these are the newer Invisalign attachments, the newer optimized ones, which are a lot better than the previous ones because they've got much better surface area compared to the other ones. But in all honesty, they're just a modification of this bevel, this horizontal bevel attachment that we talk about. And all we're trying to do is get as much surface area. Now, the only problem with these can work actually quite well now. The only problem, though, is that this is the active component right here. And if the dentist or the hygienist inadvertently takes away a bit of that active surface, you've lost all of the pushing part of the aligner. So it becomes inactive. So you've got to be really careful when you put your attachments on that you've actually got contact on those active components. That's why I still prefer the horizontal bevel attachment, because it's far more forgiving to the average practitioner. And I delegate everything to my hygienist. So I'm really into making sure everything is forgiving.
Would you then be concerned or considering the fact that would make it a bit harder to get them in and out?
Absolutely. Well, depending on the size of the attachments.
Mm-hmm.
So, for example, here on your lateral incisor, if we go to your lateral incisor, this is what we call the sash attachment, which is basically it will give you a control of the extrusive component, but also a control of the tipping. So, because if you just have the full horizontal attachment, you lose the control of the tipping. So, this is a really good appliance if you want to do a combination of both, which most patients or most teeth require that type of combination of both. But if there's one that's really overriding, like the lower left canine in the situation, I would go with that. The attachment is going to fix up that problem.
Yeah, that makes sense.
Here are these other optimized attachments, which I personally don't like at all. Okay, because here are the two surfaces, very minimal. Once again, if you lose the surface, the active component, you won't get proper tooth movement. So,
what would you be
I would
putting
be
on that
very
central?
careful with that. Now, the other thing which people don't realize, they look at that, they go, "This is fantastic." Okay. Now, David, I'm going to ask you the question. You've got a 4-6 here. Okay. You've got a minimal overbite. The last thing you want to do, honestly, is to extrude that tooth, which could open the bite further. Okay. So when I see a minimal overbite like that, I will go in here and zero out the extrusions.
Yeah.
Yeah. And so if we go into the upper arch, so the upper's not bad. Okay. The upper's not bad because there's really minimal extrusion. The 2.7 is probably extruded. So if we go into the 2.7, see, I would zero out the 2.7 extrusion as well. There's no,
especially like we're class 1 molar and canine. Like, there's nothing really wrong with the posterior bite. There's a few rotations and things, but we don't want to break what's already functioning for me as well.
Exactly right. And so, and you've got this type of this is the. So if we look at the 2.4, for example, here, I'm not even too sure why you really need an attachment on the tooth.
It's not moving a lot.
In all honesty,
A little bit of rotation.
It's pretty minimal, Miles. I mean, if you didn't rotate that tooth, would it really matter?
Yeah.
So once again, for patient comfort and to be able to get the aligners in and out, it'd be nice to minimise attachments as well. Because what I would like to do in your case, so here's your 2.1. So your 2.1 has got some intrusion there, and you've got, just for people listening, be aware whenever you've got intrusion of any of these teeth, you've got a reciprocal extrusive effect. So you need attachments on the posterior teeth as a retention mechanism, and especially on those upper laterals. That's one of the biggest mistakes we make, is we intrude the upper centrals, and the upper laterals, the aligners start to extrude out. So I think there's really just about never a case where you don't want to put attachments on the upper laterals.
Yeah, that's a good point. Again, a tooth that's often lost, it doesn't track. Can I ask a question just about the centrals? I'm thinking from a final outcome point of view, more of a restorative dentist point of view. A little bit of IPR in between those centrals would improve the fact that they're quite ovoid, and I think we'd have quite large gingival and incisal embrasures at the end.
Yep.
Is that something you're thinking about, and it's something you routinely do?
It is, but to be honest, I would probably do that in the refinement part.
Yeah. Okay. Yeah. Okay.
I mean, if you really,
see where we get to, and then yeah.
Because I think sometimes you're going to overthink everything. And I think the other thing, we talk about refinement, and one refinement is not a problem at all, because if we use the analogy of fixed braces, we have finishing in fixed braces. So even though we get everything right, and then 6 months of finishing, and I think you've got to think of refinement as the same thing. Okay. Now, you want to spend your time here planning the case, so your refinement is going to be maybe 10 or 12 aligners to finish off. The biggest mistakes we make is when refinement's another 35 aligners. And it's happened to me. You go, what's happened here? So
Mm.
That type of real fine tuning, I personally would plan in the refinement phase.
So that was a lot of information, Jeff. I really appreciate you coming on the podcast again to talk through these different points. We are going to continue with this case, obviously, as I actually get my aligners, have the tooth removed. I'm going to talk a little bit about my personal experience, and hopefully that actually gives us all, as clinicians who provide aligners, some insights into what our patients might feel as well. I really think that is a useful thing. But not everyone else should go through an extraction for no reason. Thanks again, Jeff, for joining us. I look forward to all the future episodes. If anyone wants to learn more, dentalheadstart.com/orthoed, 10% off all the courses. Jeff's a great guy. He's teaching us a lot of stuff. I'm really excited. Thank you so much.
Thanks, David. Really enjoyed the session. Thank you.
Thank you.